Hey folks, Professor Gulliver here on Saturday morning. We are doing the second part of chapter 4 now. Let's go ahead and do the screen share to make that work. We're going to share the sound and the video, and then as soon as that pops up, we'll get the PowerPoint for chapter 4. We have made it to the point of talking about blood types. I'm going to scoot that down a little bit so you can see it better. There we go. Blood types A, B, AB, and O are the four main blood types. That's what you need to know. And then we have an Rh positive and negative for each of those. My recollection is that O negative is the universal donor blood type. Let me just make sure of that because that turns out to be a very important. Type O negative blood is the only blood type safe to be used with all. So that is a very important thing. I'll just go ahead and highlight that. I seem to remember one of our graduates talking about that question showing up on boards. So there you go. We have the uh, eight most common blood types: A positive and negative, B positive and negative, AB positive, AB negative, O positive, and O negative, the universal donor type. There is a condition called erythroblastosis fetalis that develops when a fetus has an incompatibility with the mother's blood type. You may have heard of this. It's a serious situation, and that could be either due to blood type or to Rh factor, the positive or negative thing. Respiratory doesn't get involved in that very much, but you need to know about it. Rh isoimmunization occurs when you have blood cells, fetal blood cells with a D antigen. They are Rh positive, which the mother lacks. This can result in jaundice, anemia, or even more serious cardiac and liver complications. You may have heard about that situation also. Not much respiratory does with that, except possibly resuscitate the infant if the situation is bad enough. White cells you definitely need to know about. Is that next? Yeah, white cells comprise about 1% of blood volume, and they're involved in the immune response. They're larger than the erythrocytes, but there are much fewer of them. We have way more erythrocytes than we do leukocytes. They do actually leave the circulatory system to attack an infection. Other blood cells do not leave the circulation. Red cells, for example, never leave the circulation. Once the leukocytes pass the blood vessel wall, they take on an amoeba-like movement toward the infected area. It's really remarkable. There are videos of this happening on electromicrograph now, and you can actually see the white cells surround a bacteria and just engulf it and destroy it. It's remarkable that we have that capability. Another miracle of nature, in my opinion. Leukocytes can be grouped in several ways. The different types are granulocytes, including neutrophils, eosinophils. I want to mention those specifically in allergy and asthma. When you see eosinophil, very likely it's going to be about allergy or asthma. Basophils, monocytes, and they are very specifically for tuberculosis. TB patients have a lot of monocytes, and it's one of the ways we help to quickly recognize what's going on there. And then lymphocytes, like the natural killer cells, the T and B cells, you've heard about them probably in the context of HIV, AIDS, where those are, impaired. Granulocytes originate from the hematopoietic stem cells of the red bone marrow, and they have a short span of life. Some of them only live hours, others days. Yeah, and I think we've talked enough about that. Neutrophils are the ones that spike first in the immune response, and every medical person, whether you're a therapist, a nurse, a doctor, or whatever, needs to know they're the first responders of the immune system. When there is an infection, they are quick to increase in number. One of my professors called it massing an army. They're amassing an army of neutrophils to attack the infection. And then they do that phagocytosis, which is engulfing and ingesting a particle or substance usually a bacterium. Neutrophils are about 65% of all white count. Neutrophilia suggests an acute infection. Neutropenia is a concern. That's not enough white cells, not enough neutrophils, and that makes it very hard for the patient to fight an infection. Examples would be in aplastic anemia, chemotherapy, radiation therapy, uh, influenza, viral infection, severe bacterial infection. I'm going to share with you again from one of my professors years ago. It's still in my mind all these years later. With bacterial infections, our body amasses an army of white cells to attack and defeat the infection. But with a viral infection like COVID, that does not happen. The white cells actually die in battle. They die in battle. So the white cells are lower in a viral infection, but much higher in a bacterial infection. Eosinophils, again, let's just mention asthma and allergy. They're about 2 to 5% of the leukocyte count. High eosinophilia is an indication of things like Addison's disease, allergies. I already highlighted for you because we know that that shows up on boards, specifically asthma. Low eosinophils is eosinopenia and may be related to drug toxicity or alcohol abuse or substance abuse of any kind, really, or high levels of stress. Basophils, they release histamine and also release heparin. So they have a role in the inflammatory process. They're about 1% of our total leukocyte count, but they do have an important role in those areas. Monocytes are the ones I mentioned with tuberculosis, and I've got that highlighted for a very specific reason that shows up on boards. The patient's monocyte count is high, they have night sweats, and they're coughing up blood. Well, that sure sounds like tuberculosis. And on your boards, you may very well see that question. Yeah, quite a few students have. Getting a sip of coffee here. It's early Saturday morning. We're going to spend a Saturday watching football here. It's the first real Saturday of football season, so I wanted to get this recorded early before the 11 o'clock game. Lymphocytes. Lymphocytes are very important for immunity. We've got killer cells, natural killer cells, T cells, and B cells. Those are the three most important types of lymphocytes. The natural killer cells provide generalized specific, non-specific immunity. Sorry, non-specific immunity. They can actually kill some tumor cells or cells that have a virus. T cells are the helper cells and cytotoxic T cells. We heard quite a bit of discussion of these during COVID and the role that they play. Helper T cells and cytotoxic T cells. They play an important role in fighting viral infections in particular. And then the B cells, they secrete antibodies when infection or foreign antigen is detected in the body. So between the leukocytes and the lymphocytes, we get a lot of protection from infection. Nonetheless, some infections can become very serious, and even kill the patient. But we do have a lot of protection. Here's a great little graphic. I think I'll post this in the course for you so that you can see all of them on one page. That's a useful thing to do. How do I stretch that down? There it is. So you've got your leukocytes made up of neutrophils, basophils, eosinophils, and monocytes. And then there is the lymphoid lineage, as we call it. That's the natural killer cells, the T cells, and the B cells. Take a good look at that, and I'll also get it posted in the course for you. Platelets, very important for stopping bleeding. You can think of them as little plugs that go into any leak in a blood vessel, even if it's a big leak, like from a cut, major trauma or something like that. Normal platelet count's about 150,000 to 450,000, and you will see a board question about this. The patient only has a platelet count of 80,000, and you need to know that you need to be very careful drawing that arterial blood gas because the patient's not going to clot very well, and you need to hold pressure longer. You're going to need to hold pressure longer to make sure the bleeding stops. Thrombocytopenia can be a very serious situation because the patient doesn't want to stop bleeding. We sometimes have to give them vitamin K as an example to help them stop bleeding. The platelet, mean platelet volume, a measure of the average size of platelets in the blood, is a useful indicator. Older platelets tend to be smaller in size than newer platelets. So we're hoping the patient is constantly making new platelets. That's what we're hoping for. All right. And in healthy patients, they are. Two tests always done before surgery. You will always see these before surgery are the PT and the PTT, the prothrombin time and the partial thromboplastin time. These are always done before surgery to make sure that the patient will, in fact, clot to stop bleeding after surgery. There's a new thing, a relatively new thing, developed called the INR, and we want a normal value to be 1.1 or below. You need to know that. The INR is 1.1 or below. The PTT, the partial thromboplastin time, has a value of 25 to 30 seconds. Patients on heparin, for example, or maybe Coumadin or Eliquis, yeah, Eliquis, may have 2 or 3 times longer PTT. That's the how long to stop bleeding. These are very important things before surgery. Everybody has a PT and a PTT performed. Complete blood count, the CBC, is the blood test that's done just about on every patient that we see. It includes things like the red count, white count, hemoglobin, hematocrit. The differential analysis is the types of white cells and how many white cells. That tells us some very useful stuff. If the patient has an acute infection, that white count will have gone up. In particular, the neutrophils will have gone up to a significant extent. And here is a look at the entire CBC. That's a very useful thing also with all the different values that yeah, you should have a general idea of these values. For example, you'll definitely have a patient on your test with a hemoglobin that's low. You're looking here at the third thing down, or third one on the list, that's hemoglobin. For men, about 13.8 to 17.2, women 12.1 to 15.1. That difference is what you would think. It's the monthly blood loss that happens in women and not in men. Now, what we have there is a patient on boards with a hemoglobin of 8. So that's way too low. That's not enough hemoglobin to carry the oxygen, and your patient is going to be in trouble. We happen to know that the white blood cell count is also featured on board exams. The total white count should be 4.8 to 10.8. If you'd like to say 5 to 10, that's close enough to be, perfectly accurate for your test. 5 to 10. But we have a patient on boards with a white count of 28,000. 28. Way too high. So that is an acute bacterial infection. We also have a question on boards that talks about eosinophils, a patient with very high eosinophils, or as we just say, EOs at the hospital. We shorten everything at the hospital because we're busy. If you have high EOs, that patient has allergy and very likely asthma. Anemia, there we go, just talking about that. And anemia is the lower than normal amount of red blood cells, hemoglobin, or both. It actually can be both. I personally had a struggle with iron deficiency anemia. Found out my red count and hemoglobin were quite low. I did not have enough iron coming in through my diet. You may chuckle at this. My hematologist gave my wife and I a list of the iron-containing foods. It was things like spinach and liver, cooked liver and onions, spinach. What else was on there? A lot of vegetables. And I got to be honest and say, I just have not been eating that. It's a list of things that I don't eat. Broccoli was another one. It's a list of things that I don't eat. So we're trying to do better in that regard, but we're also taking a daily iron supplement because if you're not going to get enough of it in your food, you can be in real trouble in terms of making blood. Your bone marrow must have iron to make blood. And here we are talking about iron deficiency anemia which was me as the patient. Today, my hemoglobin's 13, and my red count's 6, so I'm completely normal, but that required correction, actual nutritional correction. Iron refractory iron deficiency anemia is a genetic type. I do not have that, I'm thankful to say, because mine responded very nicely to therapy. Anemia, we've got various types. You don't have to know a lot about this. You mostly need to know about anemia, but we'll mention them. Megaloblastic anemia, large amounts of red cells, um, very large red cells, and overall decrease in the number of them. So we got really big red cells, but there are not enough of them. Two types of that are pernicious anemia, which is B12 deficiency, and folate deficiency anemia. Simple thing to do, folks. Take a B vitamin supplement every day, B complex every day, and iron every day, and avoid these problems. Aplastic anemia is where the bone marrow is not making enough blood cells, and there are various causes of that. One we know for sure is Epstein-Barr. This is the reason for the fatigue that we see in chronic fatigue syndrome, which we think today is, Epstein-Barr related. Um, Fanconi anemia is a genetic one we don't see very often. It's genetic. Sideroblastic anemia, low number of red cells because the bone marrow fails to produce an adequate number of healthy cells, and the erythrocytes are unable to produce functional hemoglobin. Honestly, don't see that one very often either. Hemolytic anemia, we do see, and this is where there are a low number of erythrocytes. The low number is caused by destruction of the cells. They're actually being broken down faster than they can be made. Hemolytic, anything in medicine with an lytic, Lytic, means that there's going to be destruction of something. Something is being broken down, and that's what happens with the red cells. They're broken down. Thalassemia is one particular type of genetic hemolytic anemia. Sometimes those patients have to come in and get blood regularly, like on a weekly basis, because they can't keep enough red cells. Yeah. And finally, autoimmune hemolytic anemia, pretty rare, but there is an autoimmune version of this. I think there's an autoimmune version of just about everything today. Seems that way to me. And there are some infectious anemias. We don't see those, but malaria is one of them. You may have heard of malaria. Sickle cell disease. Yep, sickle cell, largely a disorder of African descent and Hispanics of Caribbean descent. So we will definitely see this in our patient population, sickle cell disease, where the cells are abnormally shaped. They're shaped like the letter C, and they do not function correctly. It often results in a lot of pain. There's a thing called a sickle cell crisis that the patient goes through and can be extremely painful. We do treat this better today than we used to, and happy of that. There's sickle cell trait, which occurs when an individual inherits one sickle cell gene, but not the other one. So this usually does not produce the disease. It's kind of like cystic fibrosis and some other diseases where both parents have to have the trait in order for this to produce the disease. Let's see here. Normal red cells and the sickled cells. Let's make that a little bigger for you so you can see. Those sickled cells do not do a good job of transporting oxygen, and they also are quite painful as they go through the patient's blood vessels. Polycythemia, every respiratory therapist needs to know about that. That is an actual increase in red cells and increase in hemoglobin because the patient has chronically low oxygen. When your bone marrow senses that your oxygen is chronically low, it will actually produce more red cells and more hemoglobin as a way of trying to compensate. We also see polycythemia in people who live at high altitude. If you go to Breckenridge, Colorado, a place that I'm fond of, which is about 12,000 feet elevation, folks live there. And if you measure their hemoglobin and their red count, it's higher than ours. Yeah. This is also why some athletes go train at altitude as a way of, strengthening their blood, making more Red cells making more hemoglobin before they go to their competitive event. Blood disorders that affect the leukocytes most often affect neutrophils. We've got neutropenia, something called Costman disease. I've not seen that. Have not seen that one clinically at all. It's a genetic problem. A lot of the more rare diseases you're going to find in your medical career are genetic things. Leukocyte adhesion deficiency, this is genetic disorders where the capabilities of leukocytes to respond are diminished. So you might have white cells, but they don't do a good job of attacking the infection. Leukemia, of course, you've heard of, and there are four primary types. Cancer of the blood, very concerning diagnosis. We treat it better today than we have in generations past, but still, acute lymphocytic leukemia, chronic lymphocytic leukemia, acute myeloid leukemia, and chronic myeloid leukemia. It is cancer of the blood, and pretty much all you need to know as a respiratory therapist. Lymphoma is a type of blood cancer that originates in the lymphatic system, as the name might imply. Yeah. And they're either non-Hodgkin's or Hodgkin's. Non-Hodgkin's originates in B or T cells, and Hodgkin's, characterized by the presence of abnormal B cells, called a Reed-Sternberg cell. A Reed-Sternberg cell. I recall a young male nurse in his 20s who was diagnosed with Hodgkin's disease and did not survive that. So it can be a very serious blood cancer. Blood disorders that may also affect platelets are immune thrombocytopenia, ITP. If the platelets are affected, you're going to have trouble clotting. That's the big problem. Heparin-induced thrombocytopenia is a reaction to the body to actual administration of heparin, which sometimes we need to administer, that it results in lower than normal platelet levels, and that's a problem. Hemophilia. This is the also genetic condition, disease of royalty, it's called, because many of the royal families uh, in Europe had this trait and, in fact, had the disease. It's a bleeding deficiency. The blood is unable to clot due to a missing or defective factor VIII. That is hemophilia A. Hemophilia B, it is defective factor X. And von Willebrand, missing or defective von Willebrand factor clotting protein. You needn't be an expert on hemophilia, but at least you know what it is. These patients are going to be at risk for bleeding disorders. I'm scooting this up so I can see all the slides here as we get close to wrapping this up for today. And just a few slides left. I want to be sure to go over the case study with you. You're doing great on the case studies. Thank you so much. It's just, I can see that you're studying, you're getting the answers right on the case studies. That's going to help you a lot as you move through the program. Three circulatory systems: the pulmonary circulation, the systemic circulation, and the bronchial circulation that we've pretty well covered what you need to know. By the way, another thing I'm going to do this weekend is your midterm review sheet. Students tell me they really appreciate these review sheets because they help you to focus your study. Yeah. Right heart catheterization, we actually go in through a large vessel and measure all the pressures in the hemodynamic system, and the word hemodynamic is what's commonly used for that. Hemodynamic. So if you hear about hemodynamics, it is the right heart catheter. Components of blood: plasma, red blood cells, white blood cells. We've covered that in some detail. I don't want to annotate. There we go. Okay. Technology trying to help me here with this little annotation button, but I don't need that right now. Air moving in the body travels through the nose or mouth, nasal cavity, oral pharynx. Gives you the whole list. That's also going to be published in the course. Let's read it one time. Nose or mouth, nasal cavity, oral pharynx, larynx, trachea, main stem bronchi, lobar bronchi, segmental bronchi. If it's got an eye, it's got cartilage. Subsegmental bronchi, bronchioles, terminal bronchioles, alveolar ducts, sacs, and alveoli. Pulmonary circulation, we have carefully traced that all the way through the system. I don't think we need to read that again. And that takes us to case three. 26-year-old African American female with a history of sickle cell disease has recently moved to your area and is being seen in clinic for the first time. A complete history and physical are obtained, and a complete blood count is drawn, sent to the lab. She states that she currently feels well, but has had frequent bouts with anemia and hypoxia, that's low tissue oxygen, in the last year. So, what is sickle cell disease, and how did she contract it? You obtain the patient's CBC results, and the results indicate information on the total number of each of the different types of leukocytes in her blood cell. What is that test called? So it's the different types of leukocytes in the blood sample. What is that called? I bet you know the answer by now. The patient states she is currently doing well. However, when she experiences a sickle cell crisis and her erythrocytes take on a curved or sickle shape, she experiences a great deal of pain and shortness of breath. Why does that happen? That was a 30-minute presentation, actually 26 minutes, and hopefully covered the main things that you will need to know. So I will now stop this, and later today or perhaps tomorrow, we'll record chapter 5 for you. Happy to be working with you folks. I just love respiratory therapy and love teaching online. So this is all working out great. Have a great Labor Day weekend.